For over 100 years, researchers have been questioning the relationship between changes in heart size and athleticism. Back in the early 1900s, scientists who studied Boston Marathon runners found that these runners had non-pathologically enlarged hearts, and oftentimes bradycardia. Sinus bradycardia is when the heart beats slowly, defined as the sinus rhythm typically between 40 and 60 beats per minute. Today we can conclude that heart enlargement is a normal side effect of intense exercise. This phenomenon is known as athletic heart syndrome.
Since more exercise means that the body produces more CO2, the muscles demand more oxygen, and the heart must compensate for that. But different types of exercise can lead to different cardiovascular changes. Isotonic exercise like running causes your heart to increase cardiac output, which is a challenge for all four chambers of the heart. Isometric exercise typically sees normal cardiac output, but increased blood pressure, aka systolic hypertension. Team sports usually involve elements of both exercise types, which is why athletes typically have enlarged hearts. However, these changes can also impact the body in negative pathological ways. One example of harmful changes is cardiomegaly. This is what occurs when the muscular wall of the heart thickens. This is in charge of pumping oxygenated blood to the aorta. Hypertrophic cardiomyopathy, a type of cardiomegaly, is a disease that affects the heart muscle, causing the muscle to enlarge. Thick muscles or thick walls make it harder for the heart to pump blood. Usually, hypertrophic cardiomyopathy is caused by an abnormality in a gene that codes the characteristics for the heart muscle. Pathological hypertrophy is commonly associated with upregulation of fetal genes, fibrosis, cardiac dysfunction, and increased mortality. Physiological cardiac hypertrophy in response to exercise training differs in its structural and molecular profile compared to pathological hypertrophy associated with pressure or volume overload in disease. Physiological hypertrophy is characterized by normal organization of cardiac structure. This finding is unique to an athlete's heart, distinguishing it from pathological conditions. Physiological hypertrophy maintains cardiac function over time, while hypertrophy brings complication in heart function. Let's think back to the example of the Boston Marathon runners. One of these studies' finding was that some of the athletes developed bradycardia, another type of potentially harmful changes. Sinus bradycardia has an interesting relationship with the size of your heart, since the beating of the heart is controlled by sinus nodes. There are many causes of bradycardia not related to exercise, such as heart disease, heart attacks, sleep apnea, or recent heart surgery, but this doesn't always indicate health problems. Bradycardia can be detected through tests like ECGs or arrhythmia monitors, which is used to identify the type of the cause of irregular heart rhythms, stress tests, or sleep monitors. Bradycardia can be reversed through the use of pacemakers or simple changes in one's lifestyle. So while some of these cardiovascular changes may appear to be life-threatening and of grave concern to athletes and scientists alike, not all physiological changes are inherently dangerous. The best way to confirm that these physiological alterations aren't pathological and simply adaptations is through tests such as ECG tests. It is important for athletes to check in when they're with their doctors and perform these tests in order to avoid lifelong dangerous consequences.